So we got 65-year-old male, 1 year history, progressive SOP on exertion, persistent dry cough, inspiratory velcro crackles, flapping, decreased FEC, increased FEV1 FEC ratio, decreased DRCO. And then basically predominant reticulation, honeycombing, with 5 options. Idiopathic pulmonary fibrosis, which is the most common idiopathic ILD. Histological pattern is UIP, usual interstitial pneumonia. Is characterized by progressive fibrosis. Median survival 3 to 5 years, and treatment is antifibrotics, pirfenidone, nintedanib. And supportive care includes oxygen pulmonary rehab. The only curative option is non-transplant. Second option, congestive heart failure. The similarity with idiopathic pulmonary fibrosis is dyspnea and crackles. Differences is that CHF crackles can be wetter, and there are other symptoms as well, like orthonia and paroxysmal nocturnal dyspnea and peripheral edema. And then we can do other investigations like BMP, cardiomegaly, CXR, echocardiogram shows added dysfunction. And then the third option is hypersensitivity pneumonitis. So the high effect is immune response to inhaled organic antigens like blood droppings and molds. Its presentation in acute form is flu-like illness. So fever, chills, cough, dyspnea hours after exposure, but this is like 1 year history, 1 year of dyspnea. Chronic form is insidious dyspnea and fibrosis. HP imaging is HRCT, which can show centrilobular nodules, ground gas opacities, air trapping, or mosaic attenuation and fibrosis. But fibrosis location is not basilar. It's not basal, so it's mid-upper lung predominant in chronic HP. Then the CTD ILD, connective tissue disease associated interstitial lung disease, is a manifestation of systemic autoimmune diseases like scleroderma, rheumatoid arthritis, lupus, myositis. And the presentation is ILD symptoms plus systemic features of CTD like joint pain, rash, brain knots. The HRCT pattern is not usual interstitial pneumonia, UIP, but is NSIP, non-specific interstitial pneumonia. Ground gas opacities, reticulation, less honeycombing than UIP or IPF. And then is the thickening of bronchovascular bundle. My final option is sarcoidosis. The high effect is multi-system granulomatous disease of unknown etiology. The lungs are most commonly affected. It can be asymptomatic, so it's found on incidental CXR. If it is symptomatic, the pulmonary features like cough, chest pain, fatigue. Extrapulmonary features like skin lesion, uveitis, Wolfgren's syndrome, like erythema nodosum, bilateral hilar lymphadenopathy, and arthralgia. CXR or HRCT can show the calcified thing, which is bilateral hilar lymphadenopathy. The parenchymal involvement includes reticulonodular infiltrates. Its location, not basal, but upper mid-lung predominant, just like the hypersensitivity pneumonitis. left include elevated ACE levels, which is non-specific. So for general ILD management, what if HRCT is non-diagnostic? What can we do? We can do surgical lung biopsy, which is gold standard. What can it show? Temporal, spatial, heterogeneity, normal lung, fibrosis, fibroblastic foci alternating. But the biopsy is not always needed. The general management of interstitial lung disease, so it depends on specific ILD, like removing overhanding exposures like drugs, antigens. For inflammatory ILDs, simple immunosuppression like corticosteroids. For idiopathic pulmonary fibrosis, as mentioned before, antifibrotics. Examples: tafenidone, nintedanib. Okay, so supplemental oxygen pulmonary rehab. Consider lung transplantation in advanced disease. The key takeaway is suspect ILD in patient with progressive dyspnea, dry cough, Velcro crackles. Pulmonary function tests, restriction pattern, low diffusing capacity of lung for carbon monoxide, and high resolution filtered tomography,